Hello everyone, welcome to this class. Today we are going to deal with a topic that is very sensitive and yet which researchers say has been given very less priority to over the years, and it is breaking the bad news. Now most patients, including many of us when we are patients, feel that we should be told everything about our illness, about the treatment, about the diagnosis, about all the regimens and why they are there. And this is something which we prefer. But apart from our preferences, revealing the news about illness, especially when it is a bad news, is not a simple task. It is not something black and white. In fact, it is a very difficult task for the physician. Because when the bad news is broken, it is extremely hurting and it is extremely disappointing for both the patient and the family members. And of course, it is an extremely disappointing, frustrating and embarrassing moment for the physician. Perhaps this is the reason why physicians over the years have had a lot of differences over this fact that whether the bad news should be broken or whether it should not be broken. In fact, if we go back to the researches between 1950s and 1970s, most of the physicians felt that if the news was very bad, if it had something like a chronic terminal illness such as cancer, it should not be broken. They felt it was extremely inhuman and disastrous for the patient if such a news was broken. But today, of course, the times have changed and most physicians believe that breaking the bad news in a correct way, in a way that is sensitive to the patient's needs, is extremely essential as also extremely beneficial in the long run. What is bad news? Now, since we have been dealing with this topic, which we say it is interesting, breaking the bad news, let us come to this basic factor. What is bad news? What can we say is bad and when is the news bad? Well, according to Dr. Robert Buckman, who is one of the senior most oncologists in the US and one of the best researchers in this area of breaking the bad news is anything which adversely affects and seriously affects the life view of the person. It is something which destroys hope, which tells the person that his mental and physical well-being is at risk, which tells him that there will be a lot of changes involved in his lifestyle, and most importantly, it tells him that he has fewer choices. Now, fewer choices is something very, very, very dangerous and very disturbing, because we ourselves know when we have one choice limited or one choice curtailed, we face a lot of trauma. Imagine having a huge choice curtailed out of your life. For instance, the choice to move about on your own. It is quite disturbing. Now, another fact related to bad news is that bad news is always in the eyes of the beholder. We are used to the saying, beauty is in the eyes of the beholder. Similarly, bad news is also in the eyes of the beholder. Because every person has his own aims, ambitions, expectations, plans and dreams for the future. And only he or she can say whether the news of an illness affects him and to what extent does it affect him. For most of us, a terminal illness such as cancer, which can lead to death, is bad news. But for a person, something less serious, say Parkinson's disease or chronic arthritis or chronic diabetes, can also be equally serious because it limits his or her opportunities. It may not limit his lifespan, but it limits his life choices. Why breaking the bad news is not easy. Now that we have seen what is bad news and we have explained why breaking the bad news is not an easy task, let us look at some of the factors that make it more difficult. Now, breaking the bad news depends upon a lot of variables. It depends upon the nature of the person's illness, the kind of illness, the severity of the illness, the kind of treatments that are involved, or whether treatments are available in the first place, whether a cure is possible, what kind of support the patient has economically, socially, culturally, and the like. So there are a number of factors that are involved. And this makes it a more difficult task for the physician. If the bad news is broken properly, if it is a systematic, well-orchestrated task, then breaking of the bad news can be extremely successful. In fact, it can be therapeutic for the patient and give him the time to plan for the future. On the other hand, if it is not done properly, it can create a lot of anger, frustration and mistrust of the physician. The patient may feel that his entire diagnosis and the treatment provided is questionable, and adherence may come to an all-time low. Now, let us see some of the factors that, the specific factors that make breaking the bad news difficult. Point number one, the stakes are high. Now, as we already mentioned and as we already know, all of us, including the patient who has the chronic illness, has a lot of expectations, dreams and aspirations regarding the future. And this bad news, which tells him that he or she has a chronic or a terminal illness, comes as a severe limiting factor. It limits his choices, it limits his time, and it limits a number of possibilities that he or she has. So automatically a lot of stakes are involved. The physician may hear a lot of statements like, I will never see my son grow up, or I will never see my grandchildren, or I will never be able to, my baby may not even remember me, and what will my family do without me? How will I be able to afford the treatment? And so many concerns will be there, and this can be extremely disturbing for the physician. Even expecting such a reaction can be extremely disturbing, and it may make breaking the bad news difficult for the physician. Secondly, there are a lot of emotions involved. When you break the bad news to the patient or to the family, a lot of emotions, and not just simple emotions, extreme emotions are involved. There will be a lot of anger, there will be frustration, irritation, self-pity, self-blame and whatnot. There have been even cases where patients or their families just bolt out of the examination room. That is an extreme emotional reaction in itself. Now, facing such emotions, such raw primal emotions, can be extremely disturbing for the physician, because he may not know how to react to it, and it may bring back a lot of his own past experiences and his own traumas. So that is another factor which makes breaking the bad news a difficult task. A third factor is the time pressure. Now, a diagnosis of an illness that is chronic or serious, any kind of bad news of that sort, creates time pressures, both for the patient as well as for the physician. Now, physicians, as we know, are quite busy people. They have a lot of commitments to keep, they have a lot of appointments, and they may not be able to find, these kind of singular slots of time for every patient. Now, when you're breaking the bad news, you cannot just say to the patient that you are suffering from this disease and you are going to have only so much of time left and just walk out. You can't do that. You have to stay back, you have to support the patient as he tries to come into terms with this bad news, and this requires time. And this time pressure is something which bears down on the physician. How can he or she make so much of time for one single patient? Secondly, chronic illness also has its time impact for the patient and the family. Once you're diagnosed with a chronic illness, most of us know a lot of time goes in the hospital, waiting for doctor appointments, waiting to get tests done, getting hospitalized and so on. So there are a lot of time pressures. And again, once you have dealt with these time pressures, especially if you're having a terminal illness, you have this lifetime time pressure. It's as if you are running a race against time. You have so much to fulfill and life has given you only so much of time. So this overbearing time pressure on the physician and on the patient is one factor which makes breaking the bad news difficult, because overburdening someone with a time pressure can sometimes feel really inhuman. Now we come to one important factor why bad news is not broken, and if broken, is not broken properly, and that is inadequate training on part of the physician. Now, despite the fact that physicians spend a lot of time in their lives, in their professional careers, breaking the bad news, they have to do it hundreds of times in fact, but unfortunately, despite this fact, physicians are given very less training in actually breaking the bad news. It doesn't form a part of their medical curriculum, at least it didn't form till recent years. One major reason for this probably was the existence of the biomedical model. The biomedical model concentrated a lot on the patient's physical well-being. So all the focus was on reducing the symptoms, reducing the pain, and getting the patient physically back to normal. Very little attention was paid to the emotional aspect. And hence, since very little attention was paid to the emotional aspect, breaking the bad news and breaking it sensitively and properly also became something which was kept on the back burner. Now, as we know, if bad news is not communicated properly, if the physician doesn't have the proper verbal skills and the proper communication skills, and also in addition to these skills, if he cannot, have a comprehensive view of what breaking the bad news is, if he cannot get a whole, sensitization of what the patient is, what are his various problems that he is facing, what kind of support is he having, all these factors, if he cannot comprehend and incorporate into his process of breaking the bad news, such a process is bound to fail. Many studies also suggest that apart from these communication skills and skills that require taking into consideration patient factors, there are other factors also which may affect this process of breaking the bad news, especially if the physician doesn't have proper training. For instance, there will be a lot of things that are there in the physician himself. He may be fatigued, he may be experiencing burnout, he may have had a lot of past experiences, he may have had terminal illnesses in his own family, he may have a fear of death himself. So if he doesn't have proper training, all these fears and all these inadequacies are bound to influence this process of breaking the bad news. So what can help this process in fact? And the answer is simple: training. Training is an important factor which can help the physician break the bad news in a proper way. Now, training can form a theoretical part of the medical curriculum, point number one. Point number two, role plays, lectures, a lot of feedback, a lot of sessions where other experienced physicians tell these newer physicians how to deal with the bad news. Also, experiences, live experiences where they can see experienced physicians breaking the bad news. All these things can really give the physician a capacity, a training to go about very professionally with this procedure. If not, this becomes another roadblock in breaking the bad news. And we come to this final big roadblock in breaking the bad news, which makes it all the more difficult, and that is the family. Many a time as a physician or as a health psychologist, you have families coming up and saying that please don't break this news to my mother or to my father or to my child. I will handle all the responsibilities. Let them not know this reality. Now, what do? You can't just listen to the family and hide the bad news from the patient, because that would be unethical. What you can probably do is take the family into confidence, make them sit down, talk to them, discuss their fears, and take all those also into account, so that these concerns can also form a part of breaking the bad news, and you can give probably a more sensitive reporting of the illness to the patient. Why breaking the bad news is important? Now that we have seen that breaking the bad news is not at all an easy task, yet we'll come to another factor which tells us that though it is not an easy task, it is a task that cannot be avoided. Breaking the bad news is important. And why is it so? Point number one, patients want to know the truth. Now, research right from the 1970s tell us that patients desire correct, realistic information about their diagnosis. They want to know what sickness are they suffering from, what kind of treatments are they being given, and why they are being given those treatments, what will be the possible outcomes, what is the prognosis, and a realistic picture in fact of their health status. Although research suggests that patients have always desired such kind of realistic information, the fact remains that they have not always got it, and it is high time now that physicians and health psychologists give patients the information that they have a right to. A second reason why breaking the bad news is important is ethical and legal issues. Now, in many countries such as the United States of America, a lot of issues such as informed consent, which is mandatory before you give any treatment to the patient, similarly case law, patient autonomy, and other such ethical and legal constraints make it mandatory for the physician to inform the patient about the reality of his or her health condition. So there is no way in which the physician can deny this information to the patient, even if he feels that this information is going to be disastrous for the patient, or if he feels that the patient will not be able to take it in the right way. Even in such circumstances, if the patient desires it, it becomes the ethical and legal responsibility of the physician to reveal the information to the patient. Now, just because this is ethically and legally mandatory doesn't mean that you give the information bluntly to the patient, because you can't go to either extremes. Neither can you hide the information, and neither can you go into insensitive, revelation of the information. Of course, legally, ethically, you have to reveal the information, but also in a way that is sensitive to the needs, concerns, and the life situation of the patient. A third reason, and the final reason why breaking the bad news is important, is research and clinical outcomes. Now, one of the main fears behind hiding the bad news from the patient was that it is going to be disastrous for the patient, it is going to affect him, it is going to make him worse. Now, a lot of clinical research says that it is not actually proven that any such effects really happen. Patients do not necessarily deteriorate just because they come to a realistic understanding of their health status. Now, of course, there may be a section of patients who desire that they should not be given, information about their illness, and they may desire that someone else, maybe their close relatives or others, be given this information, and it is a legitimate right and we have to respect that right. But most patients, and including many of us, if we are patients, we would desire that we be given a full, clear and realistic picture of our illness. And this in fact can be very useful to the patient, because it gives the patient the time and the space to plan for the future, to plan for a different kind of life, to plan for a situation where his choices will be limited. Secondly, it also gives the patient an opportunity to participate in decisions regarding his health and well-being. And when the patient participates in such decisions, his adherence to those decisions, to those treatments is also very good. And such an adherence also removes a lot of stress from the physician, because the patient himself is an active participant along with the physician in the treatment process. Now, the spikes model. Through this chapter, we have come to know a few things. Firstly, we have seen that breaking the bad news is something which is very important, yet it is something which is very difficult. And also it is something that we cannot escape. The bad news invariably has to be broken to the patient and to the family members. So now we are going to see how can this process be made a bit more easy for the physician or for the health psychologist and the entire team involved. So a model for this has been developed by Dr. Buckman from the Toronto Sunnybrook Regional Cancer Center and Dr. Bale from the Anderson Cancer Center. Both of them are medical oncologists, and they have developed the spikes model, which is one of the most comprehensive and useful model for health practitioners to break the bad news. Now, this model is based on the belief that just like we have stepwise instructions for any complex task, similarly a stepwise format for breaking the bad news can be very useful. It can simplify the entire process. Now, spikes, as the letter suggests, has 6 steps. In most of the situations, you may have to go through all these 6 steps. In some of the situations, you may have to repeat some of these steps, or in some situations, you can skip some of these as well. So let us go through the spikes model. So the first step, that is S in spikes, stands for setting up the interview. Now, when you as a health psychologist or as someone who is supporting the physician or the physician himself starts to break the bad news, the first thing is you have to set up an interview. You have to set up a circumstance in which the bad news is broken. Of course, you yourself will have a lot of fears and frustrations, but it is important to keep in mind that hiding the bad news from the patient is not going to do much of a benefit. In fact, revealing it to him is going to help in the long run. So this kind of confidence can be really helpful for you. Secondly, mental rehearsals are good. You can rehearse the kind of information you're going to give to the patient, how you're going to deal with the emotions and so on. Such rehearsals will also make you feel more prepared. Now, once the interview is set up, one thing you need to keep in mind according to the spikes model of setting up the interview is arrange for some privacy. You want to tell something important to the patient, and hence privacy is extremely important. If it can be done in a proper medical chamber in the doctor's room, all the more better. But if the patient cannot be shifted from the hospital room, at least you can draw the curtains around the patient and make sure that there is some kind of private space. Secondly, it is very important to involve family members. And sometimes many family members may want to come in and be with the patient at that point, but what is important is you as a health psychologist or a physician ask the patient whom he wants to be there. 1 or 2 people can be easily accommodated, and it will be very good if they are there with the patient. In fact, if the patient wants someone else instead of family members, say for instance some spiritual figure or a nurse or some other friend, that also can be allowed. Also make sure that if the patient is a child and the parents have to be given the bad news, there should be some personnel who can take care of the child while the bad news is being given. And most importantly, sit down. When you sit down, it conveys to the patient that you are not in a rush, you are not in a hurry, you are going to reveal this news to the patient and be with him till he gets over it. So sit down, make the patient comfortable, have water ready. You can also touch the patient appropriately if the patient finds that comfortable. Also important is to make eye contact with the patient. Although it may be a difficult task to do, especially since you're going to give a bad news, yet eye contact is something which is extremely essential. it makes the patient believe in you, it makes the patient want to listen to you and trust what you are going to say. Also important is to manage time constraints. One important fact you have to remember as a health psychologist going to break the bad news is that you can keep the mobile phones, pagers and all such disturbances out of the chamber when you are breaking the bad news. And suppose if you have to go in for some emergency, inform the patient and tell him that you will be back and that this discussion would continue rather than just rushing off. Because remember, this is a lifetime occasion for a patient. It is something very, very sensitive and you have to take regard of this. Now we come to the P of the spikes, that is patient's perception, assessing what the patient knows. Before you start out giving the bad news, it is also important to assess or to know what the patient and the family member already know about the illness, because they have been experiencing the illness from some time now. They may also have some kind of knowledge. It may either be true or it may be false, but they do have some knowledge about the illness. So it is very important to assess what do they already know. So before you start out, you can ask a few questions, very open-ended questions like, what do you think your symptoms are about? Or if suppose he or she has come from another doctor with a reference, what did that doctor tell you about the symptoms? What are you most worried about? Or do you feel that we conducted this test, say an MRI or a CT scan, for some specific purpose? What all these questions can do is to assess how much the patient already knows, whether that information is correct, because if it is incorrect, you may also need to correct some misinformations. And on the basis of this, you can tailor the news in such a way that the patient and the family understands it quite easily. Step 3 of the spikes is I. Now we have understood how much the patient knows, and now we have to determine how much does the patient want to know. We can't assume that every patient wants to know everything about his or her health condition. There are often certain patients, especially when they know that they are in the last stages of their illness, they don't want to know anything more about the condition. They would rather prefer that all the information be given to some significant other or some family member. So it is very important to ask the patient whether they would like to receive the information or the full information, or whether they would like the information be given to someone else. And based on the patient's preference, the information has to be given. In fact, even before you go in for some tests, as a health psychologist or a physician, you can ask the patient that since we are ordering for the tests now, and if the results are serious, if the results are something that is not positive, do you want me to reveal it to you, or would you prefer that it is revealed to someone else? You can also assure the patient, saying that there are many patients who prefer that the news be revealed to some family member. Do you also want to do the same? If the patient says yes, ensure that there is a family member to whom all these results can be responsibly given. If not, if the patient is ready to listen, it is all the more better. It will enhance your confidence and you can reveal the truth to the patient. Now suppose the patient tells you that yes, I am ready to receive the information. Then we come to the all important stage, that is K of the spikes. That is knowledge, giving information to the patient. Now there are a lot of things that we need to remember while giving information to the patient. There are quite a few S's, if I may say so. One is you have to be sensitive, you have to be straightforward, and you have to stop. When I say straightforward, which means you have to use simple language. Don't use all the jargons that may be there in your medical profession. Don't use all terms like biopsy or metastasis and so on, because the patient is not going to understand the same. You can use a better word, just spread. Instead of a biopsy, you can say we tested a sample of a tissue. Use simple terms, the patient will be able to understand it better. And secondly, when I say sensitive and stopping, the two S's are very important. When you are delivering a diagnosis to the patient, don't go about in a non-stop monologue, because the patient will be very confused and he will feel that you are very insensitive. Don't go about saying that we had this biopsy done last week and the results came in which indicate that you have cancer of the colon, which also tells you that you have only so many years to live, and so on, because that is quite insensitive. Stop and use that stops and pauses as a body language. What is very necessary is that you pause frequently. Don't give the information altogether, give it in small chunks. And with each chunk, test the receptiveness of the patient, test the understanding of the patient. You may have to stop in between and emotionally handle the patient before you continue. So be very careful to these kind of pauses and stoppages, because that will tell the patient that you are sensitive and that you really mean to help out. Also, never tell the patient bluntly that this is going to lead to your death, or that there is nothing that we can do for you. These statements are very, very depressing, because medical science always can do something for the patient. There will never be a stage where you can't do anything for the patient. If perhaps you cannot cure the patient, you can at least reduce pain, you can at least reduce discomfort, and even if you can't do that medically, you can always provide emotional support. So never use those kind of terms. You can always use something more, healthy, like, I'm afraid the news is not good, the diagnosis shows that you have, say, a recurrence of cancer, or unfortunately, I'm sorry to tell you that your arthritis has become chronic. Something like that would be more sensitive for the patient. Now we come to the E component of the spikes. Once you have given the bad news, then comes the emotional component from the patient. And as we already mentioned, the emotions may be quite extreme, they may be quite severe, and it is your responsibility to handle those empathetically. Never make the patient feel that he or she is overreacting. Let the patient freely express his or her emotions, make her feel normal, keep water or tissues ready, hold the hand of the patient if the patient is comfortable with that, reassure him or her. And you can maybe ask some questions like, I know you are very worried. Can I help you reveal this news to your child? Or can I help you in some way? Can I help you drive back home safely? All such questions can be asked, and you can actually help out the patient in such small ways. Because such small kinds of emotional help can go a long way in helping the patient, because once the emotions are spent, once the emotions are expressed, the patient himself or herself will get back to normal. Now we come to the final stage or the final step of the spikes, that is S, strategy or summary. Now that you have revealed the bad news and you have dealt with the emotions, you come to the strategy and summary part. This is planning for the future. This may involve going in for additional tests, changing the course of treatment, or treating some symptoms which the patient finds extremely disturbing, and so on. Before you start strategizing and summarizing, ask the patient whether he is ready for it. Many patients may not be ready for it at that point. They may need some time to actually accept the bad news and go over it, and then they may try to plan out. Or there may be some others who are very eager. In fact, it reduces their anxiety if they know that they actually have a plan for the future. So depending upon the patient's choices, you can look at the future strategies and summaries. Now, many doctors are uncomfortable sharing the treatment details with the patient, especially if there are not many treatment options available, especially if they had given too much of undue optimism to the patient, and so on. But what doctors need to remember, what health psychologists need to tell doctors, is that it is very important for them to take the patient into confidence in treatment, because when the patient participates in the treatment, he or she feels a sense of control, he or she feels a sense of confidence, and there are greater chances that the treatment will be adhered to and the patient will become much better. As a health psychologist, you can also offer a lot of additional support, such as whether the patient has an insurance in place, whether they need any hospice care, whether they need any caregivers for their other children, or whether they need all these kind of little supports, or they want to join some support groups, and so on. Because all this tells that the patient is not being left alone after the diagnosis. There is someone with him. What is also important in this last step of spikes is that you may have to fix up for follow-ups with the patient, because many a times patients and their caregivers are not very comfortable with just one sitting and one explanation of the breaking of the bad news. So you may have to meet with them again and again and sort out and clarify a lot of matters, and you have to give the time. It is your responsibility ethically to do this and support the patient in this regard. Now we come to the conclusion. Now in this chapter, we learnt a lot of things. We learnt what is bad news. We learnt what are the difficulties involved in breaking the bad news. We learnt, in spite of these difficulties, why it is important to break the bad news. And we also looked at one model which makes this process a bit easier. Now, as students of health psychology, what do you take back from this class? Why are we dealing with all these aspects? Because as health psychologists, you are going to be active participants in the medical process. And as far as breaking the bad news is concerned, you will have two important roles to play. One is that of information or education, and the second is that of action. As health psychologists, who are in charge of the emotional component of health and illness, you may often have to inform and educate both patients and physicians, nurses and other healthcare providers about the necessity and importance of breaking the bad news in the right way, in the right sensitive format, and how it can be catered to the needs of the patient. Your instructions and your feedback can be very important in improving this process, and it will not only lead to a lot of well-being for the patient, but it will also greatly enhance the experience of the physician. A second role that you as health psychologists will have to play apart from this kind of education and information is that of actual action. There may be a lot of circumstances in which the physician is not available to give the bad news, or you as a member of the medical team has a key role to play in the giving of the bad news. So here, all these things that you learn about the right procedures and the sensitizations that are involved in bringing the bad news to the patient come of use, because it helps you to convey the reality of the illness to the patient in a way that it will be therapeutic, in a way that increases his expectancy of life, that adds meaning to his life and gives him time to plan rather than limiting his life choices. Hence, as psychologists, as I said earlier, you have two roles, both of educating and acting in ways that will ensure that the bad news is broken in a right way to the patients.